Give us 1, 2, 3 lah once you start. Good evening, fellow colleagues and all participants. I am Dr. Rezin Kusop, the Secretary of APS. Welcome to our free live streaming webinar brought to you by Association of Private Practitioners Sabah, APS. If you have questions, please write them down on the comment section in the YouTube platform, and they will be addressed by the speaker at the end of the session. Our speaker for this evening is Dr. Timothy William. Dr. Timothy William is currently the infectious disease physician at the Gleneagles Hospital Kota Kinabalu, Sabah. He is the president of the Infectious Disease Society of Kota Kinabalu, Sabah, and also an honorary associate for the Institute Clinical Research Center in Malaysia, the Menzies School of Health Research, Darwin, Australia, and an associate investigator for the Australian Centre of Research Excellence in Malaria Elimination. He was formerly the Sabah State Infectious Disease Consultant for 10 years when he served in the public sector. He is one of the members of Ministry of Health Malaysian Covid-19 Vaccine Working Group Committee. With that, we have the authority voice on COVID-19 in Sabah this evening, Dr. Timothy William.
Thank you, Dr. Rezin, for the very kind introduction, and thank you very much for inviting me to give a talk on COVID-19. I'm trying my best to give the latest updates on COVID-19, so that's why the talk is there's a date there because things evolve very fast and the information changes literally every few days. So let's go to the next slide. Yeah. So just a bit on the coronaviruses. There are actually 7 human strains. Now the major ones that you can remember other than COVID-19, SARS-CoV is severe acute respiratory syndrome that was in 2002 and the Middle East respiratory syndrome in 2012. Now these two coronavirus outbreaks did not go to cause the severe pandemic that we are having right now. But then we have SARS-CoV-2, of which we actually don't know where it's originating from. And there's also other coronaviruses that cause the common flu. Many coronaviruses infect animal hosts. Now, I'm not going to go into too much detail on the statistics which I've been seeing in the news every single day. But anyway, today we had about 9,105 cases. And altogether, we are approaching 1 million cases in our country. So transmission, let's go to transmission. Now the main mode of transmission is thought to be droplet and then contact, aerosol, stools, and vertical transmission. Now for droplet spread, the size of the infectious particles are spread by droplets that are more than 5 micrometers, and it's in the air for only a short time, for less than 15 minutes, short distance, usually less than 2 meters, and it's possible to transmit more than 1 meter if there are circumstances such as airflow from the air condition and ventilation and sneezing. This is the main mode of transmission. So if you are standing about less than 2 meters away from the person and at a prolonged time of more than 15 minutes, the person stands a risk of getting COVID-19. Now the question now is, can airborne transmission occur? And this is the question that has been brought forward. Now, transmission from SARS-CoV from inhalation of virus in the air can occur further than 6 feet. And this is something that I need to stress. Before this, we were always saying keep a social distance of more than 6 feet with each other. However, studies have shown that it can actually travel more than 6 feet from an infectious source. And these are the areas. in enclosed spaces with an inadequate ventilation or air handling within which the concentration of exhaled respiratory fluids, especially very fine droplets and aerosol particles, can build up in the airspace, and where there's an increased exhalation of respiratory fluids. So if the, the infectious person, the person who is infected, is engaged in things like exercising, shouting, and singing, and also prolonged exposure to these conditions, typically more than 15 minutes. So the point I'm trying to make is that if a person is in an enclosed space and when certain activities are being done, such as shouting or singing or exercising with a prolonged period, you can actually consider this disease as being an airborne spread. So if you're in a room with people, it doesn't mean that you are more than 6 feet, a person cannot get infected. It does not mean that if you are exposed less than 15 minutes, you cannot be infected. A person can still be infected even though the social distance is maintained above 6 feet, and even though the person is not exposed for a prolonged period in an enclosed area. So if you're in an enclosed area, you can actually consider this viral spread as an airborne spread. So the droplets contain large and small. This is an enclosed area. Larger droplets from viral content deposit close to the emission point, while smaller ones can actually travel meters or tens of meters in long distance than the air indoors. So the 6 feet um, distance that we always quote only does not refer to indoors. Does not refer to indoors. A person can be sitting in a restaurant and a person can still get infected if the infected person is more than 6 feet away. Aerosol transmission. Aerosol transmission of SARS-CoV-2 is possible. Aerosolized coronavirus particles of less than 5 microliters have been demonstrated from infected subject. So the effectiveness of airborne precautions for respiratory virus has been compared with droplet precautions was controversial, but now it's no longer controversial. SARS-CoV-2 has been detected from ambient air samples in patient isolation room. What about contact transmission? Now, the SARS-CoV-2 virus may survive for about 4 days when the respiratory droplets settle on surfaces based on in vitro experiments such as copper, cardboard, plastic, stainless steel, and contact fomites is followed by contact with mucous membranes from the face touching. That means it goes on the fomites, you touch it and you touch your face and the mucous membranes, eyes, nose, and mouth. A person can get infected. How infectious is contact transmission? What is the latest? Current evidence strongly suggests that transmission from contact surfaces actually does not contribute substantially to new infections. It does not. So it does not mean that you cannot get it, but it just means that it doesn't contribute to the substantially new infection. So this is the criticism that we held when people were disinfecting the streets in for the hope of avoiding or reducing the people from getting COVID. Okay, transmission from contaminated surface is not, they can, but they don't contribute substantially to new infections. This is the pathogenesis. The virus actually attaches itself to the transmembrane glycoprotein. This is the spike protein that you always hear about, the spike protein. So, using the spike protein, it is by the spike protein that it gains entry into the target cell. So the spike protein of the SARS-CoV-2 virus, they bind to the surface angiotensin converting 2 enzyme receptor. Remember, ACE2 receptor, they latch on into the SARS-CoV-2 spike protein, they latch on into the ACE2 receptor on the cell. And then they enter the cell, within the cell, using the RNA-dependent RNA polymerase. Now, ACE2 is expressed predominantly on type 2 pneumonitis, upper respiratory tract epithelial cells, and small intestine enterocytes, and many, many other cells. So as long as the cells have the ACE2 receptor, the SARS-CoV-2 spike protein can bind to it. And this is the diagram. See this, the SARS-CoV-2 virus, it binds into the ACE2 receptor. ACE2 receptor. and from there it's taken up into the cell, and from here it's translated, and from the human cell now becomes a factory for making new viruses, and these new viruses then uh, are released, and these in turn go and infect other cells. So from a few viruses entering the body, they go into the human cell, they invade the human cell then becomes a factory for COVID-19, SARS-CoV-2 viruses. The incubation period, now this is believed to be about 4 to 5 days. 75% develop symptoms between 2 to 7 days, but this is a moving target with the new variants that we are finding. So there may be some changes in how fast a person develops symptoms and how fast a person becomes ill. Less than 1% develop symptoms after 14 days. So, what is the immune response? Immune response is a delayed or suppressed type 1 response during the initial infection. The viral replication then triggers a hyperinflammatory condition and a cytokine storm. You always hear this word, a hyperinflammatory condition and a cytokine storm. Then there's influx of activated neutrophils and inflammatory monocytes and macrophages. The serum neutrophils and elevated pro-inflammatory cytokines then are associated with the severity of the disease. So, you see, when a virus wants to cause a destruction to a cell, it can cause a direct destruction through the virus cytopathic effect. I mean, the virus itself destroys the cell. But what happens is the human's immune response towards the viral infection, and hence triggering a hyperinflammatory response and then further a cytokine storm. This then causes a lot of damage to the other cells. And then you have the adaptive response where the T helper cells are engaged. IgM and IgG are usually detectable within 2 weeks after the infection, and lymphopenia may be related to bone marrow suppression. Now, in mild disease, there's leukopenia, lymphopenia, and a raised CRP. But as the disease become more and more severe, there's also transaminitis, raised CK, raised D-dimer, ferritin, and LDH. So this is the spectrum of severity. Again, it's a moving target. Things are different with the different variants. About 81% are mild of people who get infected. 14% may be severe, having dyspnea, tachypnea, hypoxia with a PEF ratio of less than 300, and lung infiltrates of more than 50% within 24 to 48 hours. And 5% may be critical with respiratory failure, septic shock, and multi-organ dysfunction. Of course, people can die. It ranges from 0.4% to even 1%. So these are the common symptoms, and the most common symptoms is no symptoms. The person may not have any symptoms at all, but when they do develop symptoms, they may have headache, nasal congestion, sore throat, and these are very, very non-specific symptoms. All of us have sore throat or headaches, uh, and some of us have it every day, and we all always may have a throat irritation, but these are all symptoms of COVID-19. And then they may cough up sputum, and then later on they may develop shortness of breath, severe myalgia, chills, nausea, or vomiting. In severe disease, a person may have high fever, but take note, a person, very often people with severe disease don't even have fever. They don't have fever actually. They may have hemoptysis, decreased white cell count, and later kidney failure. So I just want to just share with you a few cases. Mr. HH, a 51-year-old man with underlying hypertension, diabetes, stroke, coronary artery disease, had chest pain on the 26th, diagnosed as inferior MI, thrombolyzed, and then the screening turned out to be positive. He had another MI, and his bedside echo was small. And if you look at his chest X-ray, it looks more like a pulmonary edema, but it's actually COVID-19 stage 4. So he was given 2 liters of oxygen. He was given dexamethasone for 6 days, and then the CRP at 44, and upon discharge he came down to 4.8. The white cell count was initially high, uh, and upon discharge it was 13.3. LDH also was high with a relatively high ferritin. Upon discharge, he was given aspirin, clopidogrel, statins, and the rest. And then this is another case, had fever, 61-year-old fever, cough, myalgia, and fatigue, went to a GP screen, found to be positive, admitted to hospital. He was afebrile, saturation of 100%, but the absolute lymphocyte count was low, C-reactive protein was high, ferritin 1390, LDH of 330, and this is how he was in stage 3 COVID, which means there are X-ray changes, but he did not need oxygen. Uh, he desaturated on exertion, but he did not need oxygen. So he started on favipiravir, which is an experimental antiviral. We do not know whether it works or not. And then given IV augmentin, but his C-reactive protein kept rising. And then he desaturated and he was given IV dexamethasone and completed 7 days. He never required oxygen supplementation. He developed steroid-induced hyperglycemia, which is why patients, especially those on diabetes, when they're giving steroids, we need to monitor their glucose. Blood culture was not good and he was discharged well. And the C-reactive protein reduced. So this is another woman with hypertension. Swab was positive, and she had a previous history of TB, fever, and myalgia, and she had afebrile on admission with a saturation of 98%. She remained afebrile and did not have any more new symptoms in the ward and never requiring oxygen. So these are a few good cases. I didn't share with you the patients who died, but there are a significant number of patients who come in very, very hypoxic, and despite everything that's being done, including giving dexamethasone, tocilizumab, respiratory support, these patients still die. So this is how the time course of the disease. Initially, when the virus infects the patient, there is a viral response where in this stage there's constitutional symptoms. They may or may not have fever, dry cough, diarrhea, and headache. In fact, many of them are relatively comfortable. They may not feel sick at all. But then they go into stage 2, the primary phase, where they may have shortness of breath, something known as silent hypoxia or happy hypoxic, where the patients are hypoxic but they do not feel breathless. So that's why it's very important when these patients suddenly appear in the hospital severely hypoxic, and patients in this stage 1 need to be monitored closely for their oxygen level so that treatment may be instituted as soon as they go into the inflammatory phase. So here they may have abnormal chest imaging and transaminitis, and then the host inflammatory response then explodes, causing a cytokine storm, and this may later lead to ARDS, shock, cardiac failure, and there's elevated inflammatory markers such as CRP, LDH, IL-6, D-dimer, and ferritin. And troponin T and proBNP may be elevated. So here you see in this viral response, in this area, an antiviral agent, a good antiviral agent, so far we have not found any. A good antiviral agent will help during the viral response because this will reduce the viral load that is the viral load and the viral replication in the patient, and this will reduce the risk of cytokine storm from happening. So this is where the research is coming out, and so far we do not have any good antiviral. Remdesivir is being used for it, and this is an old slide which includes hydroxychloroquine, which has shown not to work. And then when they go into this host inflammatory response, because it's an immune response and inflammatory response, so immunosuppressants are needed. So you have corticosteroids, human immunoglobulin, and IL-6 inhibitors such as tocilizumab. So asymptomatic infection, and this is how the virus spreads a lot from people who do not show any uh, symptoms. And that's why we have to be careful. Any person can be a carrier, can spread the virus. And true asymptomatic proportion may be actually much higher, 17 and 30% in two cohorts. And asymptomatic patients, they don't show symptoms, but they may show laboratory and radiographic changes. So the progression of the disease, there's mild to moderate upper respiratory infection symptoms for 1 week, and they recover. Many of them recover, but then there's a small percentage, about 10 to 15, may also develop dyspnea and become more severe. So what are the risk factors for severity of disease? Who are the people who become severe? First of all, I have to stress to you, even people without any risk factors, then can develop severe disease. People who are young without receptors, especially the new variants that are out there, can also get severe disease. That's very, very important. People should not think that just because you do not have any comorbidities, just because you're young, you will not get severe disease. However, having said that, the older the person is, the higher the risk of severe disease. They have comorbidities, especially obesity. Especially obesity. A young person who is obese is at high risk of developing severe COVID, cardiovascular disease, diabetes, chronic respiratory disease, hypertension, and cancer. So the disease severity is marked by the SOFA score, and the case fatality rate is approximately 50% in critical cases, especially when they go to ICU, and especially so when the system is overloaded. When the healthcare system is overloaded, when we don't have enough intensive care unit beds, HDU beds, not enough high flow oxygen and ventilators, the case fatality rate will go up when the system is overwhelmed. So in life-threatening disease, there are few disease entities. They can get severe pneumonitis, they can have ARDS due to direct, diffuse direct and indirect alveolar injury. And severe hypoxemia can occur despite relatively preserved lung compliance, and this can occur very early. And then they can also develop a cytokine storm, severe reaction akin to a hemophagocytic lymphohistiocytosis, and they can also develop myocarditis, cardiomyopathy, which may affect a subset of patients, and also disseminated intravascular coagulation. They can clot everywhere. Thrombosis, microthrombi can occur anywhere in the body, especially in the lungs, in the capillaries that are surrounding the alveolus when they are microthrombi. So you literally have very, very poor BQ, mismatch, and poor diffusion. So this is the healthy lung and a COVID lung. So the X-ray may not actually look very bad, but because of the capillaries have all filled with microthrombi, there's poor gas exchange between the alveoli and the capillaries. So how do we diagnose? I think this one you all are very familiar. The confirmed case is diagnosed usually confirmed by RT-PCR using the nasopharyngeal. Oropharyngeal is lesser, sputum, BAL, and fecal. So normally we use the nasopharyngeal, but it's very, very uncomfortable. Now we are looking at using saliva or sputum to use as a sample to diagnose COVID-19. So here you see in week 1, that's where the highest chance of getting a PCR positive. In week 1 and week 2, and even up to week 3 and week 4, the PCR may be negative. So this is very, very important. We also have to realize once the patient is better, the PCR may still be positive. The PCR may still be positive, but the patient is no longer infectious. So usually by day, for those who are not severe, usually by day 11, the patients are no longer infectious. If they are ill, the infectivity period can go up to 3 weeks. However, there's some new case reports, very, very few, very rare, where patients can remain infectious for weeks. But these are very, very in the minority. Yeah? So it's in week 2 where they develop an antibody detection. So this is a summary of the diagnostic test for COVID-19. So we are familiar with the PCR and then their antigen test. That is the famously known RTK antigen, where the test results come out within less than 1 hour, in some places 2 hours. And then we have the RT-PCR. If you have a lab, we can get the results between 12 to 24 hours. But then it's more laborious, it takes longer time. So many people are advocating using the RTK antigen. The problem of the RTK antigen is the sensitivity is not as good as the PCR, but still in a pandemic situation where we have to screen thousands upon thousands of people a day, RTK antigen may be more practical. So investigations are numerous lah. I'm just going through a few. Other than the chest X-ray, you'll do a full blood count, raise ferritin, raise LDH, CRP, procalcitonin levels. The IL-6 will be high. There may be transaminitis and D-dimer. So these are laboratory features associated with severe mortality. A very raised D-dimer, more than 1. Leukocytosis with severe lymphopenia, anemia, thrombocytopenia, transaminitis, very raised ferritin levels at IL-6, and when they have a cytokine storm syndrome with hyperferritinemia, raised cardiac enzymes, raise CRP and procalcitonin. So imaging consistent with viral pneumonia and chest X-ray, and more ultrasound of the lungs is being used now because we don't want to contaminate the radiology department. The usually also shows a bilateral shadowing, mostly ground glass opacity, and they also may have unilateral disease with local patchy shadowing and also interstitial abnormalities. Basically, it can present with any chest X-ray finding, but it usually presents like an atypical pneumonia. So this is a CT scan of a patient. You can see the consolidation and ground gas appearance after treatment on day 19 after symptom onset. Management is resuscitation, supportive, oxygenation, and ventilation. Antivirals, as I said, is still looking for a good antiviral and immunomodulatory agents. So, so the prognosis, the medium length of stay in China is 12 days when applied to all severity groups, 14.5 days to those admitted to ICU requiring mechanical ventilations. Estimates vary from location to the location. So this is the therapeutic management of hospitalized adults with COVID-19. So now if the patient is mild COVID stage 1 and stage 2, they may not need to be admitted. And now in our situation where our healthcare system is already overwhelmed, more and more people are being treated in COVID quarantine centers or even at home. Now, there are some patients who are hospitalized but do not require supplemental oxygen. The panel actually recommends, this is from the US NIH panel, recommends against the use of dexamethasone or corticosteroids. But if they are hospitalized and require supplemental oxygen, then they need dexamethasone. They need to be given steroids as soon as this happens. Remdesivir in countries where it's available, and dexamethasone plus remdesivir. But here in Malaysia, we give dexamethasone. In some centers, they may give IV methylprednisolone as well. And if the patient is hospitalized and requires oxygen delivery through a high-flow device or non-invasive ventilation, they continue with dexamethasone, but even higher doses. Sometimes IV methylprednisolone is also started. And at this time, people may also consider the use of tocilizumab or baricitinib, which is an IL-6 inhibitor. So for patients who are recently hospitalized with rapidly increasing oxygen and needs that, we add this earlier. And if all of this fails, then the patient may need ECMO. So for patients who need ECMO, dexamethasone, as you can see, our arsenal is actually limited to steroids, higher steroids and different forms of steroids and tocilizumab. Hopefully there'll be more treatment available, and we will have to wait for the trial results to come out. Now a bit on the vaccine update. So these are the vaccines that we have: the Moderna, the BioNTech, Pfizer, the Oxford AstraZeneca. So these are the two that we are very familiar with, and also the Sinovac and the Sinopharm. Now all these vaccines have a certain level of efficacy. Definitely good efficacy against severe disease and death, but varying efficacies against getting infected. So the Pfizer and Oxford efficacy is said to be about 90 to 95%. However, with the new variants, the efficacy is lower. Sinovac, the efficacy is said to be about 50%, and the same with Sinopharm as well. Unfortunately, we don't really have that much data on Sinovac and Sinopharm, but I think it works especially to prevent people from getting severe COVID. While it may not be as effective as preventing them from getting COVID, but it helps in preventing people from getting severe COVID and dying. And then we also have the Gamaleya, the Johnson & Johnson. We like the Johnson & Johnson because the dosing is only one dose. So our country may want to consider using the Johnson & Johnson, especially we want to speed up the vaccine. This is very practical. It only requires one dose. Now the side effects are pain at the site of injection, painful and swollen lymph nodes in the arm where the vaccine was injected, tiredness, headache, muscle aches, joint pains, and this all very familiar with. But then there are severe side effects in this vaccine. Anaphylaxis can occur between 5 to 8 in a million. Now, can a person die of having a vaccine? Yes, they can, but it's very, very rare. So it's wrong to say a person will not die due to a vaccine. They can, but it's very, very rare. There have been reported deaths. It's rare, and investigations are being underway. I just want to speak a bit about certain issues that are present that you may want to know. Uh, Vaccine-induced thrombotic thrombocytopenia, VITT, and COVID-19 vaccine. Thrombosis, often in unusual size like cerebral veins and splenic veins, and thrombocytopenia can occur, especially with the Oxford AstraZeneca vaccine and the Johnson and Johnson vaccine. These antibodies are directed against platelet factor 4, PF4, heparin complex, which activates the platelets. It is extremely rare, but still can occur. Still can occur. And what is the risk? 3.6 per million people after the AstraZeneca COVID-19 vaccine, and 0.9 per million people after the Johnson and Johnson vaccine. Now, this is a dangerous side effect. It is a dangerous side effect. There's no denying it, but it occurs in 3.6 per million people. So the risk is low. Despite that, I think it's important for us to explain to patients the risk. Now, for comparison, the rate of cerebral thrombosis is estimated at 207 per million in patients hospitalized with COVID-19. So, if a person gets COVID-19, the risk of them getting cerebral thrombosis is about nearly about 100, nearly about slightly less than 100 times higher. So, getting COVID means that you have a higher risk of getting cerebral thrombosis. But having said that, cerebral thrombosis can occur in 2.4 per million in the general population. So there is definitely a link between these two vaccines and cerebral thrombosis, but it's very, very rare. Now, the risk and death of serious outcomes of COVID-19, including thrombosis, far outweigh the small risk of VITT. Now, I think more for doctors who are listening, I think it's easier instead of telling the patients it's very safe, or it's not safe otherwise. I think you just give the patient the bare facts, just the bare facts. Just tell them what the risk of cerebral thrombosis. Let them make the decision. Okay, if they feel that the risk of 3.6 to 7 per million is very high and they don't want the vaccine, then it's their choice. On the other hand, we have to explain to them also the risk of having COVID, the risk of dying of COVID, this risk of getting this very cerebral thrombosis is much more higher, and allow them to make a decision. We believe in informed consent. Patients can decide. So there's no issue of us forcing them to take the vaccine. On the other hand, there's also no issue of us frightening the patients into not taking the vaccine. So a COVID mRNA vaccine also has been associated with myocarditis. There is a link between mRNA vaccine and myocarditis. The observed rate is higher than the expected rate. Hence, myocarditis is probably due to the vaccine. So the Pfizer-BioNTech vaccine and Moderna vaccine can cause myocarditis. It can cause, but it is very rare. It's very rare. So here it shows the preliminary results of those two, expected versus observed. So for females, you expect only between 12 to 17 years, you only expect about like say 2 million doses that were administered. You actually only expect this is the baseline population myocarditis, 0 to 2 to get myocarditis, but then it's observed that 19 get myocarditis, and in males 128 develop myocarditis in 2 million people. So out of 2 million people, 120 have observed to be myocarditis, whereas the background is 0 to 4. So definitely there is a risk of getting myocarditis, 128 per 2 million. Compared to if they didn't have the vaccine, you only expect about 1 to 6 in 5 million to get. So as they grow older, the expected and observed risk of myocarditis becomes less of a difference between the people who are older. So should we give the mRNA vaccines to children in view of the risk of myocarditis? That's a very difficult answer question to answer at the moment. But having said that, let's concentrate on giving the mRNA vaccine to the adults. Let's concentrate on giving that first. We haven't even done that enough before we start to consider for children, right? For children. So here, predicted case and prevented myocarditis. So for females 12 to 17 years, if they were given the vaccine, 8,500 cases were prevented. Males 12 to 17, 5,000 cases were prevented. 183 hospitalized were prevented. 38 ICU admissions were prevented, and one death prevented. But there were 8 to 10 myocarditis cases. For males between 12 to 17, 5,700 cases were prevented, 215 hospitalizations prevented, and 71 ICU admissions were prevented, and 2 deaths were prevented. So as you see, as the age goes up, the risk benefit becomes much more better for people who are older. Whereas for the younger age group, the risk associated hospitalizations prevented is less compared to if you are older. You are older. So should we give mRNA vaccines to children and young adults less than 18 years old? Again, I believe that we need to inform the parents about the risk and the benefit, and allow them to make the decision. So now, what about the new variants? WHO has labeled the variants so that we don't have to remember that it's the Indian variant, the UK variant, the Brazilian variant. So you have the Alpha variant, there's the B.1.1.7, which was previously the most predominant one in the United Kingdom, and then you have the Beta variant from South Africa, the Gamma variant, and the Delta variant. That's what that we are facing now. And then you have all the other variants of interest. Epsilon, Zeta, Eta, Theta, Iota, and Kappa. So this is the Delta variant. As you can see, the Delta variant now is spread, and there is here, you look at this graph, the numbers are all rising again in these countries due to the Delta variant. So the countries by submission, the number of Delta variants are going higher and higher, and it soon, in fact, I think now it's already now the predominant species, predominant variant of COVID-19 in many parts of the world, and soon Malaysia as well. So there's evidence that the Delta variant is causing an increase in the number of cases around the world, including Malaysia. It is more transmissible. Just how more transmissible it is, we are still awaiting data, but it's definitely more transmissible. Preliminary evidence, it shows that there's immune escape. That means to say that people who are previously infected with COVID-19 can still are still at a risk of getting the Delta variant. People who have been immunized or vaccinated for COVID-19 can still get the Delta variant. Virulence is still unknown, but we are beginning to see more and more younger people get COVID-19, severe COVID-19. Is it due to the Delta variant? We are still awaiting data. So this is something very worrying. You can see the Delta variant is increasing. This is only in June 22nd. So this is already almost 3 weeks overdue. So you can see the Delta variant is already in our country, although the Beta variant is still the predominant species. We have a lot of Beta variants here. So effectiveness of COVID-19 against hospital admission. So how effective are COVID-19 vaccines against the Delta variant? How effective? We have data from the Pfizer and AstraZeneca. We have data from the Pfizer and AstraZeneca. It does show it does have efficacy against the Delta variant. So the Alpha variant, the vaccine efficacy versus hospitalization is 78% and 92% for any vaccine. Pfizer is still good, 83, and after the second dose is still 95% efficacy. AstraZeneca is 76 and 86 for the Alpha variant, for the Alpha variant. But if you look at the Delta variant, the vaccine efficacy against hospitalization, it goes down 75%, but it's still good, 94%. For all the vaccines. In the Pfizer, it's still 94 and 96. In the AstraZeneca, it's 71 and 92%. So it is good against for hospitalization. Okay, so This is a summary of the 1,400 cases of the Delta variant. First dose, 94% efficacy against severe disease. Second dose, 96% efficacy. AstraZeneca, first dose, 71% efficacy, and second dose, 92% efficacy. Now, just remember, just because a person has been vaccinated, it doesn't mean that they will not get. So, the fact that it's not 100% efficacy and there's no vaccine that's 100% efficacy, it would still mean that people who have been vaccinated, who have had COVID before, can still get reinfected despite being vaccinated. However, the risk of them getting infected is much more lower, and the risk of them getting severe COVID and dying is even less, although not zero, is even much, much lower compared to if they are not being vaccinated. So it's very important for us not to lose heart but still be vaccinated. Now we have the Lambda variant. In June 15, the World Health Organization named Lambda a variant of interest, and it's also been detected in 27 other countries. There are 6 mutations on the spike protein, and it's possible increase in infectivity and immune escape. So this seen mainly in South America, in Argentina, Chile, and Peru, where you have the Lambda variant. Can we mix vaccines or not? Yeah, we can. The Pfizer BioNTech vaccine and the Oxford vaccine, they have done some studies that show that it does produce a robust immune response with acceptable and manageable reactogenicity profile. So, can we mix vaccines? It has been shown that you can, but studies have only been shown with the Pfizer and the Oxford AstraZeneca vaccine. So this is the latest, on, I know this is a busy chart on a summary of the vaccine efficacy. Yeah? So the Delta variant here, this one, 79 to 92% in the Pfizer, the Moderna also, the J&J, AstraZeneca, the efficacy is low, 59.8% efficacy after 2 doses. After 2 doses, and 32.9% efficacy after 1 dose in the UK. This real life ones. So we can still get. That is why it's very, very important for us to still continue our standard operating procedures in trying to prevent ourselves from getting infected. That is wearing a mask, social distancing, trying to avoid crowds. And however, even the good thing is with the Delta variant, although a person may get infected, protection from severe disease and protection from hospitalization is still very good with the Pfizer and AstraZeneca vaccine. Now, you may ask me about the Sinovac vaccine. Unfortunately, we do not have data yet. We don't have data. It's very scarce with the Sinovac and Sinopharm vaccine. Okay. So now I'm coming to the end. I know that there are many, many questions. Can pregnant women get the vaccine? At the moment, for Pfizer vaccine, the Ministry of Health advises that it can be used between 14 and 33 weeks of pregnancy. And the AstraZeneca also 14 to 32. Sinovac also 14 to 32. So they advise that we give the vaccine between this duration, and it's also safe to take vaccine if the mother is breastfeeding. With that, I'd like to thank you very much. We have to fight this disease together, and it's within the country and internationally also. And with that, I'd like to thank you very much for your kind attention. We are going through a very, very difficult period in our country, and I pray and I wish that all of you would stay safe and hopefully not get the infection. Thank you.
Thank you very much, Dr. Timothy, for that very informative update on COVID-19. We have a few questions here. The first one, I think you have expected this already, from Jia Yi Tiong. Can ivermectin be antiviral drug?
Okay, can ivermectin be an antiviral drug? Well, studies have shown, the studies, the in vitro studies have shown that ivermectin can kill the COVID virus, in vitro studies. However, the levels that are needed to when we say antiviral, we mean killing the virus, lah, is very, very high. Uh, there, there have been postulated there are other mechanisms where ivermectin can work. Right now, the jury is still out there. We cannot say conclusively that ivermectin works. There are a few studies that are big randomized controlled studies that are being done to see whether ivermectin can be used or not. However, based on the studies that have already been done, we cannot make a conclusion. I think the next question is, Doctor, if we haven't made any conclusion on the efficacy, is there any harm in giving ivermectin, since we haven't made any conclusion here? Let's just give it anyway. Well, uh, uh, I can't really recommend one way uh, or another. I can only recommend what the WHO and Ministry of Health and the CDC have recommended, that you can only use it in trial settings. Okay, but anyway, this is something that we are very interested in, and let us just wait. We will have to wait for the data, and unfortunately, I'll have to wait for the data before I can, many of us can give any recommendations. But right now, should you use ivermectin or not? My personal opinion is I don't think you should use ivermectin until we get more data on its efficacy.
Thank you, Dr. Timothy. I think the next question is you've answered already, but I'll read it anyway. Can a person develop COVID infection after the vaccination? There have been a few cases where people who were asymptomatic developed symptoms and were found COVID positive after the vaccination. And following that, I think Renoka wanted to clarify some more. Were these people already asymptomatic carriers and the disease become full blown after the vaccination? And I'll just read the whole question now, from the same person. Is there a place for prophylactic antifungal therapy to prevent black lung?
Okay. Now, can a person develop COVID infection after vaccination? Answer is yes. But the risk of them getting another infection is much more lower compared to a person who's not been vaccinated. And can persons who are asymptomatic develop symptoms of? Yes, they can, even after the vaccination. Remember, the efficacy is not 100%. Okay, it may range between 85 to 95%, which means to say that people who are vaccinated can still get infected, especially with the new variants that are out there. Now, in India, there are many cases of mucormycosis because of the use of steroids in patients, especially in patients with very severe um, COVID. And there are many, there possibly reasons why it is, because they're very immune suppressed. But it's also been said, it's postulated, it may be due to the oxygen supply in India that may have predisposed the tanks, and the contamination that may have predisposed the patients to have mucormycosis. Right now, so far as I know, we haven't seen any cases of mucormycosis in Malaysia. So is there a role for antifungals? No, not yet.
All right, thank you, Dr. Timothy again. Next question is from Dr. Nelson. How long after the vaccination, if the patient died, can be considered due to the vaccine?
Okay, well, uh, this is a difficult question because um, let's say a patient gets an anaphylactic reaction, or which is a known side effect, or a vaccine-induced thrombotic thrombocytopenia, and or they develop myocarditis um, after the vaccination and they die. We It is plausible that they died because of the vaccine. However, we also have to remember there are many other factors that can also cause these conditions. Because you must remember, we're not giving the vaccine to just 1,000 or 2,000 people. We're giving the vaccine to millions of people. And every day, people, even without getting the vaccine, also develop these conditions, cerebral thrombosis. They can also get myocardial infarctions. They also get myocarditis in a setting. So how do we know whether it's due to the vaccine or not? Well, I've already explained to you earlier. Myocarditis and vaccine-induced thrombocytopenia is definitely associated with the vaccine. But if a person develops that, to be sure that it's due to the vaccine or not, we do not know. We can only infer. So I think most doctors would want to know, what do we tell our patients before we give the vaccine? Should we tell them the vaccine is dangerous? Should we tell them the vaccine is safe? What I suggest is for you all just to give them the facts. Give them the risk of developing complications, encourage them to take the vaccine, but leave the final decision to them.
Thank you. Next question is from Dr. Sophia. Any research done on antibody production post-COVID vaccination? Any suggestion for booster dose?
Okay, research is currently being done on the anti-production because it has already been shown that the antibody levels wane after a certain period after the vaccination is being given. So whether there's another booster dose, there's been suggestion that Pfizer, especially Pfizer, is suggested a third booster dose, but that has not really been approved or established by the US FDA. So research is going on. There may be a booster dose in the future. They may.
Thank you. And the next question is from Rinuka Nambiar again. What about a patient who becomes COVID positive with symptoms during first trimester of pregnancy? Will this cause NTD?
What is NTD? Neonatal death, is it?
I'm not sure also.
I'm not sure what NTD stands for. Um,
They probably
okay, the
explain
next
that
question.
further later.
Does the current vaccines work with new variants? Well, we do know that the mRNA vaccines work to a certain extent, but for the other vaccines, we're not really sure yet.
All right, Renuka have just clarified.
On neural tube defects, okay. Um, I don't know the answer to that, yeah, Rebecca. I'm sorry.
And the next question from iMedics. Just wondering what is the maximum duration between dose 1 and dose 2 of current vaccine
Well,
given to be still
uh,
effective?
the I mean, it's been advised that you should take the vaccines within the period that's been stipulated because that is what has been studied. But I do agree sometimes you can't take the vaccine because a person is sick or due to logistic problems and this and that. The between the first and second doses you can get it, but just make sure it's not too far apart. I think the question is how far apart it can be. Can it be as far as 3 months or 4 months or 6 months? So far, I can't give an answer to that because there are no studies being done yet. If we space the vaccines further.
Thank you, Dr. Timothy. I've got also some question from WhatsApp group. The first question is in GP setting, if for certain reason, uh, yeah, please address the question.
Okay, UITI symptoms do not want to get tested. Would it be necessary? Let's say a person has UITI symptoms, so you suspect the patient may have COVID. So this is a patient that has not been diagnosed as COVID. Would it be reasonable to start the patient on DEXA and ask the patient to stay at home until asymptomatic? No, you shouldn't give dexamethasone without a diagnosis for any reason whatsoever. Um, what is your view on people at home and start buying finger oximeter and checking themselves while being asymptomatic? Yes, I think they should. They should get a mass oximeter. Lots of people asking can take alcohol after the vaccine. I don't think there's any specific prohibition in taking alcohol in small amounts, but I think this is the general rule not to take too much alcohol after any vaccine for that matter.
Thank you, Dr. Timothy. I think we have come to the end of our webinar today. It has been very informative, and thank you for all those people who have participated. We have about 90 plus uh, members participated at the moment. And again, we are sorry that the CPD points are not yet approved, but we are still trying to get it approved and will be granted to those who have registered, even though the event has already passed now. We will see you again in 2 weeks' time with another topics and another speaker. Thank you very much.